Hello friends, this is a case of total laparoscopic hysterectomy and we will demonstrate you a skin to a skin how to perform total laparoscopic hysterectomy. So, this is the patient, here is the pubic symphysis. So, we will put the index finger over the pubic symphysis and we will make a shape of a diamond by our both the hand and thumb will be the telescope and one snuff box is one port, another snuff box is another port. So, this is approximately 5 centimeter above the umbilicus and this is approximately 12 centimeter of the uterus with the abnormal uterine bleeding and we will perform the total laparoscopic hysterectomy. So, this is a small stab wound given on the midline and then we will introduce the varus needle perpendicular to the abdominal wall and oblique to body. You should not go much oblique, you should not go perpendicular also. Ask your assistant to lift the abdominal wall and point your varus needle towards the anus, so that you will be perpendicular to abdominal wall and oblique to the body. Advantage of this way is that you will never ever go to the great vessels like aorta or vena cava and it will not go to the preperitoneum also. So, this is the irrigation test. After that, suction test, and you can see this ball is sinking down. In the ethicon varus needle there is a ball that gives you beautiful hanging drops test. So, now the insufflator is attached and we are keeping the preset pressure at 15 and slowly waiting for the actual pressure to reach to the preset pressure. So, this is a 45-year-old female. So, she will take approximately 3.5 liter gas and you can see slowly homogeneous distension is forming. And CO2 is entering into the abdominal cavity. Initially, flow rate should be 1 liter per minute and once the 1 liter gas has gone, you may increase the flow rate to 3 liter per minute. However, the eye of the varus needle will not allow to go more than 2.5 liter per minute. So, we can see now abdomen is getting more and more distended and the insufflation is continuing. So, approximately 3 liter gas is now inside. And now actual pressure is almost reached to the preset pressure. And we will take the varus needle out and now enlarge the incision to 11 mm, so that we can put the optical port. Now, this is the first optical port and that is introduced perpendicular to the abdominal wall by a screwing movement. Index finger should be pointed towards the sharp end and then we, as soon as we will enter, we will have a hissing sound. This is the hissing sound which is visible, which is audible. Now, we always keep the trocar at the tip of the trocar, we put some betadine and now we will attach the insufflator tubing and now the maximum flow rate is increased to 10 liter per minute and now the telescope is inside. After that, this second port will be 5 centimeter lateral and below the umbilicus and approximately 18 centimeter from the upper border of pubic symphysis. This is the first arc, that is 18 centimeter and the second arc is 24, where is the telescope. So, just like a compass, this is the 18 centimeter and this is the 7.5 centimeter lateral and below the umbilicus this is the second port. So, this surgery we will perform by 2 ipsilateral port So, this is the second port, which will be the surgeon's right hand for the active instrument like ligashore, harmonic, thunderbeat, NSEAL, whatever you use, and this will be the right hand instrument. This is 5 mm. And now another 5 mm, again 7.5 centimeter lateral and below, approximately 1 to 2 centimeter above the anterior superior iliac spine, and this will be surgeon's left hand for holding the atraumatic grasper or Maryland during the suturing knotting. So, these are the only 3 port which you will perform for total laparoscopic hysterectomy, and once all the 3 port is introduced, after that head will be put down and the table also go down. So, head down and table down, the head and table is going down. So, the first step is all the small bowel should be moved above the sacral promontory, so that aorta should be visible and both the common iliac vessel is also visible. So, we can see this is aorta is visible, and then there is a aortoiliac axis and both the common iliac is visible. So, this is sacral promontory, this is right common iliac, here is the ureter, this is sigmoid colon, here is the left ureter, this is the external iliac artery, you can see pulsation of the artery and the peristalsis of ureter. This is triangle of Dohm, here is the round ligament, and this is the genital branch of genitofemoral nerve, this is the external iliac artery. So, this is the triangle of pain, where 2 nerves are going, GFN, that is genital branch of genitofemoral nerve, and lateral femoral cutaneous nerve of thigh. Here is the deep ring and this is the inferior epigastric vessel. This is the pubic symphysis bone, here is the Cooper ligament. This is the median umbilical ligament which is visible, and these are the both medial umbilical ligament. This is the right, this is the lateral umbilical ligament, that is inferior epigastric vessel. This is the entire area belongs to bladder, this is the bladder. Here is the sigmoid colon, this is the uterus, and we can see some fluid in the cul-de-sac. That is normal, that much amount of fluid is normal, and we can see the uterine hump, and then we can see the uterosacral ligament as well. Now, coming to the left side, this is triangle of Dohm of the left side. Here is the psoas muscle, this is the GFN nerve. This is the Cooper ligament of the right side. This is the inguinal ligament of the right side, starting from pubic tubercle going up to anterior superior iliac spine. Some of the adipose tissue in the peritoneal cavity is normally floating. So, now diagnostic laparoscopy is over. After that, we will do cystoscopy and we will put the infrared ureteric catheter. So, this is the right ureteric orifice, and here we are introducing the striker U kit, that is the transparent ureteric catheter, in which we will put the fiber optic of the ureter, and we will use L10 light source, and this fiber optic will illuminate the ureter. 15 centimeter of this U kit ureteric catheter should be introduced. So, this is the left side, and now this is the right side of ureteric catheter is introduced. So, almost all the good company now making the infrared ureteric catheter, and almost all the new light sources has the attachment for the infrared, so that you can illuminate the ureter, and then the ureteric injury is almost nil. So, after doing that, we will start now the laparoscopy, and here we are again inside the abdomen, and we can see both the ureteric catheter is illuminating. Now, we are using here the uterine manipulator, and this is the uterine manipulator which we are using is the Mangeshkar uterine manipulator. So, this is the Mangeshkar uterine manipulator. This is the insert of this uterine manipulator, and there are many type of uterine manipulator: Clermont-Ferrand, Mangeshkar, Marwa, Rumi. So, here this is the insert. You have a different size of the insert which you can use, and there is a tenaculum, and after that this is the sheath which you can put over the uterine manipulator. After that, you have a different sizes of the colpotomizer, and then you have sheath, and then you have a insert. So, this is the insert which will enter into the cervix, and then it will do the anteversion of the uterus which you can introduce, and after that you can lock it, and depending upon the size of the uterus you can lock it here. And now this is the handle, and there is a lock here. This lock, if you can rotate, it will lock at that particular point. The tip of the insert of the uterine manipulator must be 2 centimeter smaller than the uterine cavity size, so that it will not perforate. And you have a different sizes of the colpotomizer, that is 2.5 centimeter, 3 centimeter, 3.5 centimeter, different sizes of the colpotomizer also you can use it. So, generally whenever you use uterine manipulator, you should understand the functionality of the uterine manipulator, because different uterine manipulator work different way, and different method of locking and inserting is there, and all has a different size of the tip and different size of the colpotomizer. So, according to the size of the cervix, you have to do that size of the colpotomizer. There is a cervical sizer also, that will let you know, but if you do not have a cervical sizer, by hit and trial you should try to find out that which size of the colpotomizer will be appropriate. So, now this insert is introduced and it is locked. So, now we have introduced the uterine manipulator, and now the assistant will give the cranial traction, anteversion, and the contralateral traction. So, this is important that your assistant should know how to assemble and disassemble the uterine manipulator, and which direction, 6 o'clock, 9 o'clock, 3 o'clock, 1 o'clock, 11 o'clock, which direction which she should introduce and which should give the traction. You should also use a shoulder support. That shoulder support will give you, so that when you will push the uterus cranially, then the patient should not move towards the anesthetist. So, this is how you will disassemble the uterine manipulator, and before using you must clean it properly, either in the hydrogen peroxide plasma or even the rapid Cydex, that is ophthal paraldehyde also you can use. So, this is the demonstration of the Mangeshkar uterine manipulator, and after assembling it we have introduced it inside, and then anteversion and cranial traction will be done. So, this is the contralateral traction, and we will start with the round ligament, that is approximately 4 centimeter from the uterus, and we will perform this surgery only by 3 port. One is supraumbilical and 2 other ipsilateral. So, this is round ligament is done. After that, fallopian tube, and you can see that uterus is not in the pelvis, it is coming in the abdomen, and it has a complete contralateral traction. So, after round ligament, fallopian tube, ovarian ligament, then you can go 2.5 centimeter over the broad ligament, but more than 2.5 centimeter you should not go blindly without separating the anterior leaf of the broad ligament and without separating the bladder. So, now the right side of the dissection is complete. Now, uterus will move at 3 o'clock position, and similarly you will take the left side of adnexal structure. Now, the left side is also complete, and then we will take 2.5 centimeter over the broad ligament. You can see both the ureter is distinctly visible due to the striker U kit, and after that we will separate the anterior leaf of the broad ligament. With the left hand you should stretch the peritoneum, and with the right hand you can keep on separating the anterior leaf of the broad ligament with the vibrating jaw of harmonic, and left hand should make a anterior window, and slowly bladder peritoneum should be separated, and assistant will keep on moving the uterus from 5 to 7 o'clock. So, this is done, anterior leaf is separated. After that uterus will be at 6 o'clock position, and then we will separate the bladder. Bluntly, bladder should be pushed down and bladder pillar should be lateralized. How you will know that bladder is going and vagina is exposed? Vagina will look like a pearly white color with the crisscross pattern of the vessel, and the bladder pillar must be lateralized. We can see this is the facial plane, bladder is down and pillars are lateralized, so that you can have the proper skeletonization of the uterine vessel, and then coagulation will be easy. So, now the anterior leaf is done. Now, we will do the posterior leaf of the broad ligament, and for that uterus will go at 1 o'clock position, and you will keep on, assistant will keep on moving the uterus from 1 to 10 o'clock position, and you will separate the posterior leaf of the broad ligament. We should remain above the arc of the uterosacral ligament, so that vaginal part of the uterosacral ligament should be not cut ideally in properly performed TLH, and that is why the TLH has a less chances of wall prolapse. Now, uterus will again go at 3 o'clock position, and this is left side of the uterine artery is being coagulated. So, left side is over, little bit Macan rod which is left behind also is coagulated and cut with the ligature. Now, uterus will go at 9 o'clock position, and right side of the uterine artery is being coagulated and cut. So, now both the side of the uterine artery is over. After that we will start doing colpotomy. Just little bit vein is getting coagulated on the right side, and then with the harmonic you will start colpotomy above the vaginal arc of the uterosacral ligament, and while you are performing the colpotomy, assistant will keep on rotating the uterus, and proper cranial traction is also recommended. So, this is the posterior colpotomy, and uterus will be rotated by the assistant, so that you can optimize the colpotomy without any shorting and without overshooting. So, now the hysterectomy part is over. After that, we will remove the uterus, and then if you have to perform the BSO or salpingectomy, you will do it. So, here tube is given anteromedial traction, and with the ligature you can do the salpingectomy of the left side and then right side. During that you should avoid the collateral damage and devascularization of the ovary. So, better is to avoid the bipolar, because in bipolar you have 6 millimeter of collateral damage. Ligature is also bipolar, but it has only 2 millimeter collateral damage. So, it has less chances of doing devascularization of the ovary. So, this is left tube is removed, and then same way right tube also will be removed. So, now the hysterectomy part is complete. Here is a stone holding forceps which is introduced through the vagina, and the tubes were taken out. After that, suture will be introduced through the vagina, and here is the number 1 vicryl, and we will do the valve closure by using a curved needle and vicryl. This is the right uterosacral ligament, which is taken with the bite or with the right vaginal posterior vault, and then this is anterior vagina. Cranial traction is important to prevent injury of the bladder, and this is the first row of the closure, and in which we will not do lock, but we will must include the vaginal epithelium as well. This is the third bite over the left side of the uterosacral ligament, which is included in the bite as well as anterior leaf, and then reaching to the left corner we will lock the suture. And after that, once it is locked, how to lock? Just you take the suture through the loop and it will get locked. After that, you can tighten the first layer and you can pull the tail as well, so that it will slide like a purse string and the first layer will be closed. So, this is locked. If you have a 4 port, then assistant can pull the tail, but generally we perform all the TLH only by 2 working instrument and 1 telescope. So, we do not have any assistant helping. So, we will return back with the same curve needle, and during returning back every time we will lock it. So, now reaching to the right corner, and then this is, we will include again the right uterosacral ligament. And then one surgeon's knot will be applied, and the vault is closed. We can see the total blood loss in this surgery is hardly 5 ml, which you can see that is the same fluid in the posterior cul-de-sac which was present during the diagnostic laparoscopy. That much is only there. Throughout the surgery, we have not used any suction irrigation. And this is the last knot of the surgeon's knot for the vault closure. Alternatively, you can use barb suture, or you can also use the extracorporeal square knot. So, now the suture will be cut out and it will be removed. Needle can come out with the safely through the 5 port. So, this is over. Thank you very much for watching this video. Have a nice day.